Thank you for inviting me. I'm very proud and honored to be here. It's a big pleasure to see the audience here. And so I have to speak about the robotic radical prostatectomy. So Mark was trying to kill me, but I'm still alive. So the history of robotic is an old story. You see the opinion of Leonardo da Vinci in 15th. But this is a very interesting slide coming from a humoristic journal in France, showing an operative room in the year 2000. It looks like the Da Vinci system. So in 2000, we have published the first paper in robotic radical prostatectomy. So it was shown here predicted here by these people. And as you know, until 2004, laparoscopic surgery was increasing. And in fact, due to the evolution of the system and of the instruments, so the robotic take the place of pure laparoscopic surgery. And from 2004, you can see that in 2011, more than 350,000 people was operated by using the robot in the world. In terms of publication, urologist was the first, and the prostate was first topic on robotic, after that partial and cystectomy. But as Mark told, the randomized study has a poor number of publications. Most of the publication was in the report series. So there is two kinds of publication, registry series and the expert series. What about registry series? This is a medical practice series showing that, in fact, both robotic and retropubic had poor results in terms of continence and potency, as you can see here. Maybe the retropubic is worse, but we cannot say that in the medical series, the robotics shows a fantastic progress. But this is a very nice publication in the nationwide inpatient sample, about 20,000 patients, showing that most of the patients was operated by the robotic, 61 over 38%, and the laparoscopic is quite nothing. And the results are very interesting, showing that in terms of transfusion, intraoperative complication, overall complication, and the length of stay, the robotic is better than open surgery. 7,000 patients versus 7,000 patients around. What about the expert series? This is a very interesting publication with 30 retropubic versus 14 laparoscopic and 14 robotic expert series, showing that in all cases, including transfusion, positive margin, continence, and potency, either one bundle or two bundles, the robot was better in terms of complication. They were equivalent around 10% of complication in all cases. So what about complications? See here the data from Karolinska, which is a hospital registry and not the urologist registry, showing in terms of complication, transfusion, complication, infectious complication, bladder reconstruction, and all Clavian grade, the robotic was better. This is a Tevari publication. I think he will speak about that later. In terms of high Clavian grade, robotic was better than open or laparoscopic surgery. About cancer control, again, Tevari showing that robotic is twice better than laparoscopic or open surgery. And this is our series, and we have done we have reviewed 1,300 laparoscopic and 1,000 robotic, a follow-up of 50 months, showing that in terms of operative time, blood loss, blood transfusion, bladder catheterization, hospital stay, robotic was better than laparoscopic surgery. In terms of medical complication, equivalent 4 and 5%, and in terms of surgical complication, 7 and 10%, it was not different. In terms of anastomosis complication, the robotic was much better in terms of acute retention, in terms of the bladder reconstruction, mostly 0.7 versus 1.7. In terms of biologic-free progression, there is no difference between laparoscopic and robotic for PT2, PT3A, and PT3B. And in terms of functional results, you can see here that this is self-administered questionnaires, and you can see here if the patient has his continence is 95% in the case before surgery. He is continent, is no pad and no leakage. He had at 12 months 75% of continence for robotic, 68 for laparoscopy. It's not significant. And so after 24 months, there is not a significant difference, but the trend is better for robotics. If we do intrafacial surgery, we have good results, 88% in 24 months, but at 1 month, 33% of the patients are fully continent without pad, and for using a treatment of continence, you can see that we use any treatment 0.7% for robotic and 3% for laparoscopic approach, including macroplastic balloon, suburetral sling, and artificial sphincter. No, we didn't have any use of artificial sphincter in the robotic series. For potency, you can see that we have 69% of potent patient after 24 months. For robotic, 55 with laparoscopy, while around 80% was potent before surgery. So the difference is only 10% loss of potency for robotics after 24 months, but if you use the intrafacial surgery, you can see we rise to 37%, 33% of potency with robotics. So, finally, the trend today is to associate the results in margin, continence, and potency. You can see that there is some discrepancy. The trend is around 60%, but Shilakov showed that it was important to see if it's objective response or subjective response, and the difference is very important. In objective response, we have it shows that 44% of patients had trifeca for robotic and 76% if we use a subjective response system. That means a medical chart. In our series, in objective response, we found 54% for laparoscopic. About the cost, you can see that if you do more than 300 patients, the additional cost is around 2,000 euros. But we know that in fact, if you see, for example, some medical treatment proposed today to a patient rise to 5,000 euros per month, so the robotic cost, the additional robotic cost is not so high finally, if of course we find better results. So in conclusion, we think that through the literature, even if there is not enough randomized study, the robotics seems to give better results in terms of operative time, blood loss, transfusion rate, and hospital stay. In terms of oncologic results, finally, there is no difference in biologic-free progression. But there is probably higher positive margin rate in PT3. We have to be careful about that, and the selection of patients has to be done, but the trend today is to operate a young patient with PT3. And in terms of functional results, probably the trend today, even if it's not shown clearly in the literature and in the series, there is an early recovery of continence and potency for robotic patients. Thank you very much.